Hi, my name is Lois Starr. I am a clinical geneticist from Omaha, Nebraska, and I am thrilled to be with the Myrie community today and so happy to be a part of this conference. I will be speaking about genetics today and kind of just an overall summary of Myrie syndrome. So my talk is Understanding SMAD4, the genetic cause of Myrie syndrome. I'd really like to thank Inez and Dr. Lynn and the other planning committee members for including me in the lineup for the conference. Thank you. So the objectives for this talk today are to discuss that pathogenic mutations in SMAD4 are the cause of Myrie syndrome, that this gene is in the TGF-beta pathway, and that there is another diagnosis that it can cause. We'll talk a little bit about that and how important it is to have molecular confirmation, if possible, for a diagnosis of Myrie syndrome to be made. But then a lot of our talk is also going to be to review the cardinal signs of Myrie syndrome and kind of make sure that we're all on the same page for many of the other talks that will be subsequent to mine, kind of digging more into specifics of Myrie syndrome. So some of the history includes that in 1981, Selma Myrie reported 2 unrelated male patients in Washington state. Since that time, many years later, Hopkin and Lindor both reported some patients that were described to have laryngotracheal stenosis, arthropathy, prognathism, and short stature, referred to as LAP syndrome. And then later in 2011, the Legoff and Valerie Cormier-Dares group, as well as the Caputo group, found that pathogenic mutations in SMAD4 were lining up to be very consistently causing Myrie syndrome. Then in 2012, Nora Lindor put together that LAPS and Myrie were on the same spectrum, and now we use Myrie syndrome as the preferred eponym for the condition. And we no longer really use the acronym LAPS, though it is descriptive of some of the parts of Myrie syndrome. So in discussing any diagnostics for a genetic condition, I kind of bring it back, take many steps back, and from the beginning, how do we think about genetic material? Well, it is separated into discrete compartments called chromosomes, but they all work together. They're all part of the same system. So much like a set of encyclopedias where they're all part of the same set, but they do have, they are separate. And so chromosomes are separate by number instead of by letter. And I realize many of you are too young to recognize encyclopedia set, but some of us remember going through them when we were younger at least. And so chromosomes are labeled by number. So 1 being the longest, including the most genetic information, all the way to 22 being the smallest. Well, actually 21 is the smallest, but they're very close and they were kind of misnumbered, I guess, many years ago. And then there's a set of sex chromosomes. I have 2 X chromosomes, and then for biologic male would be an X and a Y chromosome for the sex pair of chromosomes. Myrie happens to be on chromosome 18 on the long arm, 18q, and is right about in here. Well, SMAD4 is right about there, which causes Myrie syndrome. All right, so in order to look at a single gene, we can't see mutations that are causative for a condition like Myrie syndrome, a single gene disorder, looking for a single mutation by looking at a karyotype or a set of chromosomes like that. So we have to pull out of the chromosome a sequence. And so if this is the chromosome here, we're really looking at just a codon or base pairs of DNA to make our diagnosis. So much like the comparison to the encyclopedias, where we're not looking for a whole extra book or a large extra chunk that we could see with the naked eye or under a microscope, we're looking for a single letter change or kind of a misspelling of the SMAD4 gene to be able to molecularly diagnose Myrie syndrome. You're going to see throughout my talk many photos of patients, and they were all provided to me directly from the individuals or the families. And it's probably my favorite part of my talk is all the different faces that you're going to see. All right, so when we're doing sequencing of any gene, we're looking at that base pair DNA level. We're looking usually in a gene of interest. If a geneticist or other physician or care provider thinks that they know what condition a patient has, they might just pick that single gene. And so with some of our experience with Myrie, we might be confident enough to say, I would just sequence the SMAD4 gene or even just that part of the gene. But most of the time, no two patients are alike. Everyone is unique. Everyone has hundreds and even thousands of genetic changes. It's part of what makes us all different. And so often that confidence isn't there, or even for other resources like time, we might choose to go a different route and either sequence many genes at the same time, or even something called a whole exome, whole genome, etc., to find a diagnosis. Myrie syndrome is quite rare, and so many care providers and physicians don't know this condition very well. And so they're more apt to land on the diagnosis if they do one of these larger panels that includes SMAD4. So exome and even genome sequencing now, some people are getting genome sequencing on a clinical basis even, are done where we're not just choosing SMAD4 or even a handful of genes, we're literally looking at thousands of genes. So in a DNA, long DNA sequence like this, it's just choosing certain chunks that are either just the coding regions, as in with an exome, or theoretically throughout the entire genome, all of the DNA. So that's at least the way that it seems in theory. But a warning is that we really aren't. So for those of you who maybe had exome or genome sequencing done, do know that it wasn't as if every single base pair of the DNA was sequenced and at least not interpreted and recorded. There are many, many genetic changes we all have, and not all of those are reported, but something that's known to cause disease, like the specific pathogenic change in SMAD4 that we know can cause Myrie syndrome, would have been reported. We also appreciate this testing because it solves many puzzles that clinicians have when trying to find the diagnosis of patients who don't always have a clear-cut diagnosis, or if we don't have as much experience in certain areas, this kind of more global sequencing that's looking for things that we didn't even know we were looking for is tremendously helpful. And then I want us to not forget that you can be diagnosed with more than one thing or have a medical incidental finding from big sequencing panels like this that most often hopefully are helpful, but we are very careful when utilizing this testing that the consent needs to be appropriately done. So I know this is a very busy slide here, but want to bring up that SMAD4. So when you see in all capital letters, italicized like that, SMAD4, that's when we're referring to the gene. So SMAD4 provides instructions for making SMAD4, the protein. And so when it's not italicized, we're often referring to the protein itself, which is involved in transmitting chemical signals from the cell surface to the nucleus. So you'll see that in this cartoon here that I got from one of Dr. Lynn's slides. It's actually where SMAD4 is having a conference with SMAD2 and 3 and bringing it into the cell nucleus to kind of impact the TGF-beta pathway genes. So the transforming growth factor beta pathway is really important with growth and division, and critical in many different body tissues and systems, especially the connective tissues and vascular tissues. So for Myrie syndrome in particular, we know that there are gain of function mutations in contrast to loss of function at position 496 and 500. These are the two codon positions that have been found that when there's a change there, and there's, I believe, 5 different mutations that we've seen there that can are consistent with causing Myrie syndrome. And I don't believe that we've seen any patients with those mutations at these positions that are not found to have any features of Myrie syndrome. So it's really very clean in how this has worked out. Now, loss of function mutations in SMAD4, not at these codon positions, but at other positions, are associated with a different diagnosis. And so if you've ever Googled this, or friends or family have Googled SMAD4 and genetics, one of the first things to come up is probably a condition that's much more common than Myrie syndrome called juvenile polyposis syndrome. And this condition causes a predisposition to polyps in the colon and colon cancer. And so a very different condition as compared to Myrie syndrome. I love this photo too. It's a good one. All right, so inheritance pattern. Myrie syndrome is considered an autosomal dominant disease. So in contrast to autosomal recessive, X-linked, other different types of disorders that you might have heard of, Myrie is considered dominant. Now, most often when a condition is dominant, we will see it going through a family, inherited from parents to child and then to their children. But Myrie syndrome is while dominant, we only need one copy of the gene to have the significant change causing the disorder. It really isn't quite inherited that way. We only have one familial case, and this is very recent, where there was a mother who has Myrie syndrome in hindsight, and she has 2 affected children. But to my knowledge, this is the only familial case, not just reported, but that's been known to be the case. If you know of others, please do let us know. We would love to hear about that. So that was in Earshot just here recently. There are likely other families out there, certainly with, over the many, many years that the potential would be there. Certainly there probably have been, and maybe even many generations where Myrie syndrome has been inherited, but no others that we know for sure with the molecular confirmation. We anticipate that SMAD4 pathogenic mutations impact fertility, and likely do for perhaps both men and women, but that's also a consideration of why most often the pattern is that we see it de novo, or in the first patient that we meet, and both parents are completely unaffected. And by the way, an opportunity for me to bring up that there's absolutely nothing that a parent could have known to do differently to prevent those changes in SMAD4. It's just something that happens by chance. So when I talk about different genetic and rare diseases, I like to bring up that the reason that we want to find a molecular diagnosis or that genotype is because it's going to help us medically manage and take care of the clinical picture or the phenotype. We don't mean to just throw around labels necessarily, but I'm sure as many of you can appreciate, it's wonderful to have an answer, but then also know, how did other patients do that had this condition? What can we know to look for? So it's not about putting on a label necessarily, but in a way, having that answer helps us with what not to miss. And so when we know a genetic diagnosis, we can go through the long list of things that may have been associated with that condition, which is what we're going to do today, and try to not miss things. Not every patient is going to have all of the things that we bring up, but they could have many, and some that maybe it would be helpful to know about before they show up to help optimize medical treatment. So again, the diagnosis of Myrie syndrome, just to be really clear, is when we've got the characteristic clinical features coupled with preferably a pathogenic SMAD4 mutation consistent. Is it possible that we might find another codon position? Absolutely, completely possible that we might. Wouldn't that be interesting? But as of right now, it's just these two specific positions in the gene that are known to cause Myrie syndrome, which is really unique and special to Myrie. There's not a lot of conditions where that's the case. Usually there's many mutations in a gene that can cause a specific condition. So just a real big overview is that the characteristic facial features can be quite mild. We'll go through those. They often have short stature, compact habitus. We know they can tend to look quite muscular, etc. Hearing loss is very common, and it's a multisystemic connective tissue disorder. So connective tissues being most of the tissues outside of the central nervous system, or the brain and the nerves and the organs. Most of the other tissues are connective tissues. And then also Myrie syndrome has a unique quality in that it can cause a progressive and proliferative fibrosis. All right, so the craniofacial features can and often do consist of these. Not every patient has all of these, of course, but things we watch for are the inverted triangular face, the shortened palpebral fissure, or the length of the eye from here to here. Deeply set eyes is quite common. Maxillary, or the kind of this area here under development. A short philtrum, or from the bottom columella of the nose to the top of the vermilion border of the upper lip. They can have a more narrow mouth, a thin vermilion of the upper lip, and a more pointed chin, or prognathism. And that can develop more and more over time. And of course, the phenotype, the clinical presentation of Myrie syndrome changes from how infants look to toddlers, children, and in adults. So this slide was actually courtesy of Dr. Lynn. Many of you may have seen it before, but I love how she brings together several of the different faces that we've seen of Myrie syndrome from many different groups. So from France, Turkey, Mexico, Hong Kong, Italy, we have many different faces that we can look at. Many things that are similar, but some subtle differences depending on background, of course. So hearing loss is quite common in Myrie syndrome. I think in the vast majority of patients with a confirmed diagnosis have some level of hearing loss, most often conductive, but also sensorineural and mixed hearing loss is seen, and occasionally a bone dysplasia in the ear's inner bones is noted. Cardiovascular, this was one of the first things that brought my attention to Myrie syndrome in meeting some of my first patients who are very near and dear to me. So the cardiovascular system is very importantly impacted, and unfortunately, some of the cardiovascular impacts can be life-threatening, including changes in the aorta and including some narrowing and even in the peripheral arteries. Pericardial disease, or the sac that covers the heart itself, can become inflamed and have very significant issues with pericarditis. A restrictive cardiomyopathy, hypertension, congenital heart defects are seen. We've seen tetralogy of Fallot and other more complicated heart defects noted, but usually they're more mild. So the structural changes are usually more mild. Persistent ductus arteriosus, or PDA, has been seen probably the most frequently. And a post-traumatic proliferative response also has been seen on the surface of the heart and with the pericardium. Dr. Mark Lindsay is a wonderful colleague and a cardiologist, and he's actually speaking directly after my talk. So I can't wait to hear that. The respiratory, airway, and pulmonary systems are also impacted. Choanal stenosis and even atresia, or an inability to get anything through the choana or the upper airway here. Laryngotracheal narrowing, restrictive pulmonary disease, that's in the lower pulmonary tracts. Obstructive airway disease, asthma is often diagnosed, but maybe often isn't really what we're looking at. So here in this photo is actually from a scope where we're looking up at the level of the trachea in one of my patients, where we're looking up, and sadly her trachea completely stenosed shut. And so what you're looking at is a lack of an airway where there should be one. And then in this lower slide here is significant fibrosis in lung tissue. Dr. Bernie Kinane is giving a talk later at 5 p.m. and then also tomorrow at 10:45 to more discuss some of these issues, especially pulmonary. And then Dr. Michael Cohen is speaking tomorrow more on some of the airway and ENT issues at 1:05 tomorrow afternoon. All right, so GI issues are also very common. Lots of different feeding and growth issues. Significant constipation has been noted. Consider looking for a tethered cord if clinically appropriate. We've seen pyloric stenosis both in infants, but also as a later onset. And duodenal strictures or tightening at different levels of the intestines have been noted as well. And Dr. Sophia Duzgo-Huge, I know I'm mispronouncing that, I'm so sorry, is speaking later this afternoon. She's absolutely fantastic. She's on the professional advisory board for Myrie syndrome as well. And skin issues are also fairly frequent with thickened skin. It can feel quite stiff, especially on extensor surfaces. And we've seen decreased facial creasing with different facial expressions, etc. Really nice senior picture here. All right, so musculoskeletal features. Intrauterine growth restriction is something that we see a lot, small for gestational age, very frequent. This compact habitus that sometimes is described as a muscular type habitus, but we prefer compact. Limited joint range of motion, brachydactyly or short fingers, lordosis or this curve of the lower back, this distinctive posture where the arms are held out a bit, a stiff gait. It can often be noted. Dr. Nicola Brunetti-Pieri is going to be speaking more about the musculoskeletal features tomorrow, which is sure to be great as well. Neurodevelopmental issues are very common. It seems most of the families that I've been in contact with will say that their child or loved one with Myrie syndrome does have some unique characteristics from this perspective, but at the same time often can do very well. So academic challenges, perhaps compared to family members, are frequent. Autism, we've seen that range, but often maybe even up to half of patients. Profound speech delays can also be very frequent. The newborn hearing screen can be normal at birth, and then the hearing issues can come up later. And so perhaps that is also contributing to those diagnoses. Gross motor delays, so things like sitting and walking, can be behind peers. And we've often seen anxiety as well as a frequent finding. Dr. Amy Morgan is talking more about psychiatric issues in particular later today. All right, so that fibroproliferative response, which is so intriguing and fascinating, and it's something that is fairly unique to Myrie syndrome. This does not occur in many conditions. It can occur in the skin, in the ear canal. The airway is very problematic. The mediastinum, or in the chest, around the organs, we've seen that. Pericardium, or that bag around the heart. In the pleural space, in the lungs, in peritoneal space, around the organs in the gut, and also in joints. And so these photos here show some of the experience with my patients. This was a scar from a fundoplication. You can see it's getting very tight, hypertrophic, a lot of much thicker scar than you would anticipate. This is at a trach site. This is from just a simple biopsy site without much trauma at all. This is on the surface of the heart. And then this is a lot of fibrosis seen in a lung. All right, Neoplasia, a very important publication came out a couple of years ago from Dr. Angela Lin and her group, reporting on numerous individuals who had some sort of neoplasia. Endometrial was the most common, with 3 women reported to have neoplasia of the uterus. And so we recommend a low threshold to screener test, but nothing, no specific early screening necessarily. And of very important note, no one with findings similar to juvenile polyposis syndrome, the other condition that pathogenic mutations in SMAD4 in other locations as compared to Myrie syndrome have been reported. So if anyone happens to be aware of excessive polyps in anyone with Myrie syndrome, we'd really like to know about that. Please also catch Dr. Lin's talk. She's giving a couple, but specifically on cancer tomorrow at 3:30 as well. All right, so that is, I can't believe it, but I'm almost out of time already. And so I do want to thank everyone in the Myrie community. You have no idea how much I have learned from all of you, and especially Dr. Lin for her mentorship, Dr. Lindsay, and all of the physicians and care providers. It has just really been a wonderful experience for me, and I look forward to seeing more Myrie patients in the future. Individuals with Myrie syndrome are incredibly important to me and our group, and I'm so grateful to be a part of it in this conference. Also, all these awesome photos I have are directly from patients and their families, and with full consent to show to you guys today. So I will be looking forward to your questions, and again, sincere thanks.
Thank you, Dr. Starr. That was wonderful. I think we're going to go into a live Q&A. I do see your face. Welcome. Thank you for being here. So we did get quite a few questions that came in through Q&A, so we'll roll right into those. So the first question came from one of the Myrie teenagers. Can you explain what gain of function is? And then there's a second part of that question.
Yeah, well, I can sure try. And I know that it's been a topic that's kind of in the news right now in relation to COVID. So that's a little bit of a different discussion as far as experimentation goes. But when we're talking about a specific gene and different variants in that gene, we like to think about what are those variants doing to the function of the gene. And sometimes it's telling the gene not to, maybe not to make the protein or enzyme in a sufficient amount. That would be typical. Sometimes it's telling the protein that it can function, but just not up to the same level. That would be typical. That we think about more with loss of function. So when there's haploinsufficiency, you might see that in some of the things that you're reading, where a gene isn't functioning as much. When I think about a race of 2 individuals an individual who, for some reason, got a sprained ankle or something, and it's more difficult for them to get as far as quickly in the race, would be sort of what the protein is doing. When we think about gain of function, which is what we see in the two codon positions that we know associated with Myrie syndrome, we actually think about that protein taking on a new role, sort of a new and different function, rather than just not functioning up to par. In Myrie syndrome, we think that SMAD4 is taking on an extra function or doing something kind of outside the box compared to just not functioning up to par. Dr. Mark Lindsay, who's speaking next, he might be talking about that a little bit. He's probably a lot better explaining that than I am. But thank you so much for your question. And Justin, it's so great to see you. And thank you for having me. I'm just so excited to be a part of the conference. Thank you.
And thank you for all the work that you've done. The second part to that question was actually in relation to COVID-19, because there is a lot of talk about gain of function. The question was specific if there is a correlation or if that's just unknown at the moment.
No, I mean, there is a correlation in that they're talking about having viruses do things that they're not supposed to be doing. So it's kind of an extra function. But to me, I think about what they're worried about in the research realm is not something that I would want our patient population worried about as far as, taking on new roles. They're talking, I think, in the news about how that gain of function is in relation to the different animals that the virus is going through and how it can, I wouldn't want to compare the two too much. I'd want to think about them pretty differently, but good question. I have the same question as well, is how can things like this be associated? So I completely understand.
Yeah, absolutely. The next question was actually about facial recognition software. I see in here that this will be answered tomorrow. But Dr. Starr, real briefly, can you comment on the facial recognition technology? Is that something that could be trusted, or you could give some light on?
That's a perfect question. Can it be trusted? So I would be very cautious to rely on facial recognition for confirming a diagnosis, but for giving a clinician ideas of what a diagnosis could be, it's really excellent. It's something that I'm shy to do often, because if I'm meeting a family for the first time, I find the consent for facial recognition sometimes can be a little bit awkward. And I would never do it without consenting a family, honestly. So I don't always use it, but there is something that I think any of you can go on. It's an app that's called Face2Gene, using the number 2, Face2Gene, and you can download this app and you can actually, I've done it on myself before, and there's a range of different conditions that it's thought that I've had, and I think that Myrie syndrome is actually probably a reasonable condition to think that Face2Gene could be fairly accurate. What they're doing is compiling many photos of people who have the facial features and the comparison of where the palpebral fissure ends and starts in reference to the top of the ear, and like many, just hundreds of reference points. It can be really helpful, I think, in a responsible diagnostic odyssey, but it wouldn't be something that I would say, I suspected Myrie syndrome. Face2Gene says that that's a match for your child or for you. End of story. I would always want to go on to the molecular confirmation. I think that's really important.
Okay, that was great. Thank you. This one actually came in from Facebook. So all of you out there, thank you for using different mediums to get us those questions. We'll get to as many as we can during the Q&A. Next question is from Facebook. Is having 2 upper lobes in your lungs a part of Myrie syndrome, to your knowledge?
2 upper upper lobes. I wonder if they're referring to if there was so you have 3 lobes on the right side and 2 lobes on the left side. And so, Justin, am I hearing 2 upper lobes? I wonder if it's someone who on the left side, I know it's possible to get a 3rd lobe, and so maybe they're referring to it as an extra upper lobe.
I'm not
Angela,
sure.
are you?
Yeah, Dr. Starr, let us respond to that and get some more clarification, and we'll come back with more on that one. And we'll just go on to the
Okay.
next question. To your knowledge, or any knowledge of why menstruation is so heavy for the girls?
You know, one of my suspicions is I worry that the inflammatory process can be very upregulated in Myrie syndrome, which is part of this post-inflammatory fibrosis that we can see. And so I worry that the uterus is probably especially prone to that. And so with extra inflammation, then comes the healing process after that, and all of those that post-inflammatory response then causing excessive bleeding afterwards. But I don't know if any of us know for sure what's going on there, but when there is menstruation, it's because the uterine lining had a kind of a thickening process, and then it's sloughing that. And I think that when it's going through that, maybe that our girls and women get extra tissue inflammation and thickening, and then therefore it can be really difficult. I know, and I definitely advocate for. I know many of us, we don't like to do medical intervention unless it's completely necessary, but I would encourage people to have a very open mind with how tough this can be on the girls and women with Myrie, and to consider options to slow that process down, either with medications or we have had at least one patient, to my knowledge, who had an IUD placed, and she found it to actually be very helpful. It made me nervous because I don't like implanting anything or doing procedures in Myrie syndrome unless at all necessary, but it did work out okay. I'm certainly not giving that advice, but if you've already done it or something, we know of one patient that it worked out well for. But I would encourage considering other types of managing that, so that you either reduce the number of cycles or the significance of them, because I know it can be really, really more difficult than maybe it needs to be.
That's great. Great answer. Thank you. The last question that we have from Q&A: what are some challenges to progress and research for those with Myrie?
Oh my.
It's a very deep question. I think we'll touch a lot of that throughout some of the talks.
I think one of the things that is so hard for me, especially having a relationship with so many, is I want to, and this would be true for a lot of rare disorders, is it's hard to get the number for a good randomized control trial, like a cohort, and something that would be really fair to those that got a treatment and those that didn't. I know a lot of us have ideas of different things that we could try, but with each one of the special individuals or your children, it's hard to say, you know, I just love to have a model where we could say, let's move forward, you know, with Kristen, let's try her on this medicine, and then let's see how she does without that medicine. And we can't do that. We have to pick those treatments just very individually and wisely. And it's really difficult with small numbers, especially to do the gold standard for research, randomized control trial, to see if it's really beneficial over the long run. We have patients who have this, you know, almost devastating fibroproliferative response after a surgical procedure. And we have other patients who do fine with it. And so telling you to avoid that procedure that might involve an increased quality of life, it's just so difficult for us to make those calls. So I would say the biggest challenge, in my opinion, is that I wish, and this is why Dr. Lindsay's work with the mouse model is so important too, is because we can't experiment with each individual necessarily, or we sort of are, to be honest, just using our best judgment in what treatments might be helpful.
That's great. And one more question came in, and we have about a couple minutes until we get to take a break. But the last question is, this goes back to the menstruation period. What at the age of 17 years, my daughter does not have a period? What kind of testing should be done by a gynecologist? Thank
Yeah,
you. Question.
very good question. So it is definitely time to look into that. There would be a battery of hormone tests that they would want to look at, but also with the anatomy. Frankly, with Myrie, I could see that there could be an anatomical issue there also, especially if she's having cyclical pain or other issues. So I think you're probably going to be looking at a physical exam, perhaps a very thorough one. And so keep that in mind. Make sure that you're in with a very sensitive and solid gynecologist, and then also a range of hormone tests. We have seen both delayed menarche, but also quite early. So that first period being delayed and also quite early for girls with Myrie, but 17, you're absolutely right to pursue. Something is going on there. I sure hope they can figure it out. And Justin, can I throw out that, I know that Dr. Lynn and I and our whole board, if after hearing all these things today, if you have a unique story, or if you know a family, another familial case, things like that, I know myself and others, we would love to hear those stories. We never want to intrude, of course, but if you're willing to share, please don't be shy, because I know we would all appreciate hearing about your unique experiences, or anything that you've learned about that you think is unique to Myrie.